Chronic pain. I think we've all experienced some kind of level of pain at some point that may have stopped us from doing what we want to do with our lifestyle. But what defines chronic pain? Data shows that if we were to scan 30-year-olds with no pain symptoms whatsoever, 40% of them would show wear and tear changes. So what does this mean for us? I'm going to bring Dr. Jill Hamilton into this conversation today on one of our MedFit episodes because I think pain is something that is quite definitive for a lot of people, and it can either be mentally restrictive or physically restrictive, and that's the bit of separation that we want to try and help you understand today. So, as always, I'll have a little bit of a fitness input on this, and it's pretty straightforward when you look at it from a fitness standpoint. But when you look at it from the medical perspective, and we start uncovering what's going on inside of the medical world, when you start looking at chronic pain specifically, I will catch my breath. You start to look at what defines chronic. Because there is a period of time, which I've just found out by speaking to Dr. Jill Hamilton, that chronic pain defines a period of time before you then are actually labeled with chronic pain or diagnosed with chronic pain, and how you should be managing this as a in-the-moment kind of thing as well as long-term. Because, again, if something you are wanting to do, it is being impacted by physicality, you are experiencing a repetitive injury or a repetitive pain from doing something, we need to get to the root cause of why this is happening. And I think if you don't, and you're leaving this over a period of time, you start to fall into that category of being in that degenerative phase. I knew I was going to mess up saying that word, because the longer you leave something underlying that doesn't go diagnosed, you're at risk of prolonging or even impacting the greater severity of how that thing is going to be impacting you later on in life. Now, again, if this is a physical thing, a fitness thing, there are things that we can do. But when it comes to chronic pain and being diagnosed with chronic pain, I want to bring Dr. Jill Hamilton into this conversation to explain what chronic pain really is. And from conversations that we've just had, there are a lot of people that go to see GPs that go for diagnosis and they want to understand, why am I experiencing this pain? What does this pain really mean? What category am I falling into? And my reasoning behind this is that I want to know if people are mentally and physically looking to use this as reasoning to not do something because they're experiencing something at that moment in time. So, first question for you, Dr. Jill, is what is chronic pain?
So, chronic pain actually is just a time frame. All right. So it doesn't give us any indication about how severe that pain is. So it could be very minor pain, or it could be pain that's really debilitating. You can't get out of a chair. The actual term chronic means that you've had it for more than 3 months. So I think sometimes I get patients that come and they say they've got chronic pain, but actually what they're trying to tell me is that it's severe pain. But actually the term, when we use it medically, just means that you've had pain for more than 3 months. So once you've had pain for more than 3 months, it's a slightly different beast than just a normal injury, okay? Because if you do something where you say sprain your ankle or you have a minor injury, that pain that you're getting is a warning signal for your body to stop doing what you're doing, have a bit of rest, let everything heal, and you'll get better. Once you start experiencing pain for more than that 3 months, that's why it's quite important that we've got like a demarcation for it, from sort of acute pain, which is less than 3 months, to chronic pain, is because actually the nature of the pain changes at that point, in terms of how you're perceiving the pain, how that pain is processed from wherever it's originated, and then when you perceive it in your brain. So it's actually quite a different thing for GPs to then treat and get involved with and try and help the patients.
Right. Okay. So I'm going to kind of go with what I've experienced in my past and also a lot of people that I've worked with over the years, because I think one of the things that stops people from wanting to do things is feeling something that they know is a repeat injury, a repeat pain, and mentally they may have said to themselves, this is a lifelong condition that I've got. Now, I am somebody that has suffered with some pretty severe injuries when it comes down to physical movements, and I've done 4 discs in my lower back, but no operations or nothing, but they all went at the same time, and that was due to multiple reasons, and I won't get into the ins and outs as to why, but 4 discs when it rendered me like bent over for like 2.5 weeks, couldn't breathe when it happened, had to lay on the floor, all of these other things. And at no point, and again, I went straight to an osteopath because I was understanding that this was more of a movement based issue than a pain management issue. And I was in severe amounts of pain at that point in time. So when I'm looking at this from fitness, is most people say I've got shoulder pain, knee pain, hip pain, back pain, and they explain this as I've got chronic pain in these areas. And I think this is where that differentiator between what that word actually means in day-to-day life and then using that same word in GP terminology. Because if I was to look at chronic pain, and what I've heard from people when they explain chronic pain is it's just something that's unbearable. It's a pain that I can't stand to bear. And this might be 2 or 3 days into an injury, and I've now got chronic pain. But the reality is, like you're saying, that chronic pain is actually labeled that it's pain that's persisted over a 3-month period of time. So acute pain, let's just quickly touch on the acute pain so we can kind of box that bit off first, because there is a topic of fibromyalgia that we want to bring into this as well with regards to what chronic pain looks like, because it is something that people manage long term. So acute pain, just explain how if an individual was feeling discomfort, impingements, some kind of recurring issue, is the process of not just elimination but treatment, the first thing they should do is go to a GP? Because I think that's what a lot of people think is, I've got shoulder pain, I've got back pain, I'm going to go straight to the GP and it's now their problem. What is acute pain, and what is the process that somebody should be thinking about when they're looking at trying to manage a short-term pain problem?
Okay, so I'll probably use myself as an example here. I do a bit of running, and I've certainly built up my running over the last couple of years. When I got into running, I think I was like everybody else, that it starts something, a new health drive. You get into it, you start enjoying it, you get better, then you probably push yourself a bit more than you should or your body's capable of. So I can remember going for a run with a friend who was fitter than me, faster than me, trying to keep up. And I think I had some wrong footing and I twisted my ankle really badly. It was awful. It was 10 out of 10 pain. I thought when I took my trainer off, I was going to, I thought my foot was going to come off. I felt sick. I couldn't walk on it. Properly dramatic, So when I found out it was just a sprain, I was really surprised that actually something could be that painful. So I went home. Obviously, even as a GP, I wasn't quite sure if I'd fractured the ankle or not. So I went home. I didn't do anything other than rest, elevate, put ice on it. And then over the course of the evening, it really became swollen and much different to the other ankle. Then I thought, oh gosh, I've probably fractured my ankle. Went off to the local walk-in centre because I thought if it's fractured, I might need some treatment, might need a cast or, a supportive boot, something like that. Saw a nice nurse. I got my ankle x-rayed. It got reported as not a fracture, just a nasty sprain. So at that point, I then went home, carried on resting it, made sure I had supportive shoes, things like that. And I was quite happy just to, have some paracetamol, ibuprofen, and it got better. So I would say that probably after a period of 6 to 8 weeks, that ankle pain was pretty much gone. Okay, still a bit niggly, not as good as the other ankle, but it was fine. So I did go and get medical treatment for it because I wanted to check that it wasn't a fracture. But then after that, I sort of pretty much knew the expected time course for that to heal. Okay, so that whole episode is an episode of acute pain, okay, which was healing. So the body is brilliantly adaptive and will regenerate, and now that ankle is nearly as good as the other ankle was. Probably still always have a weakness, but it's nearly as good. So that whole sort of thing is an episode of acute pain. But had that ankle healed and had some of that pain gone away, but then every time I ran on it, and now this was a couple of years ago, if that pain was still there and it really bothered me, that would now be an episode of chronic pain if I'd had it more than 3 months. So, I mean, that's just an example of a sports injury, but you could have other injuries. So you could have, somebody goes for an operation, say they'll get their they have their gallbladder removed or something, which is a pretty common operation, which is done through keyhole. So people have quite a good, quick recovery from that if they're quite fit. But, if the pain from that operation didn't go away after your 6 to 8 weeks, which is what would be expected, then that would come into the chronic pain as well. So that's why it's important to differentiate the two, because up to about 3 months, you probably don't need a lot of medical intervention unless it's getting worse and worse. Some painkillers and rest, it will get better. After 3 months, it really should start being investigated.
Here's a kind of a caveat on that, because I'm thinking the acute pain, I think a lot of people experience something at some point, and say it's a shoulder impingement, a back pain, like you say, maybe it's a surgery pain. And I think because of obviously hospitals, GPs, booking appointments, time, and all of these things, people can leave things, let's say, maybe longer than what's really advisable. And they kind of maybe try to self diagnose at this point, and they do a few things for themselves. Now, in that acute pain window, that -3 months part, they start getting the problem, the pain persists, but they're maybe trying to manage this out themselves. Say the severity increases in that 3 month window, and they could have done something earlier on about this that would have maybe have kept them in the acute phase rather than moving into the chronic window. You explained to me before we started talking on this podcast that when you move into that chronic window, the exploration phase of figuring out what the problem is becomes much deeper on a much deeper level, because it's not just about finding out what's going on at surface level. There's a root cause behind something else, which is why it's become a chronic issue and not an acute issue. I think as somebody that has had multiple injuries over the years, and I generally, if I know that just through experience and my own knowledge, that it is probably more of a mobility issue for me than a long-term chronic issue, that I know to go straight to somebody to get the issue resolved as quick as possible, in the sense of not just pain management, but I'm looking to try and get the root cause of the problem resolved so that I can get back to doing what I'd like to do on a day-to-day without kind of feeling restricted in any way. Now, obviously, granted, I know some people that go through chronic pain that has maybe come from surgery. They don't have that luxury, because it's not just going to see somebody that can quickly give you a few exercises or movements to free up an area so you're not in as much pain. But when you start to go into that chronic window and you've come out of that whole, I've managed this myself in the acute window for up to 3 months, and it's actually getting worse, is a person, because this is my curiosity behind this, is a person then the cause of moving from acute to chronic because they didn't get seen early enough?
Okay, so that's an interesting one. And I think there's going to be lots of different examples, and I'm not going to be able to say in 100% of the cases it's going to be this or that.
Yeah, understandable. Yeah, it's just more of like an observation. I'm thinking, like, are we the thing that gets in our way when we could be getting better quicker without going through the whole, I'm trying to manage this out myself?
So, I mean, what I would say in the example that I gave, I did go and get some help straight away, because I wanted to know, I don't want to walk around or put pressure on a broken ankle if I've got one. If it's a sprain, there's not much I can do. It's just going to heal. If it's a fracture, you need to get something done. So, I mean, obviously, yes, in that case, if I'd done something and I was really unsure whether I'd caused some real damage or not, you do need to get in there quickly and get it sorted out. But I think in terms of, yes, anything that is very severe, anything that isn't improving with, just your regular bits of advice. And, people like, if you go and see your local pharmacist, they're quite good at giving you a bit of advice and knowing actually when you should be going and getting some more specialist advice. So going and seeing a GP or nurse practitioner. But I think anything that is very severe, anything that you feel that is unmanageable, and especially like if it's a foot or something, if you can't physically wait there or walk on it, that could be an indication of something. So you need to go and get that sorted. And that's again, other things that can cause pain acutely are infections. And so anything that doesn't sort of follow the normal time course of, having a bit of, pain relief and rest, you should be going and getting some help from that. I mean, it's difficult to know. I know it's difficult to get GP appointments, and we have some on the day appointments, and we have appointments you can arrange in advance. And quite often, I'll have people booking in, say, an acute pain problem. Say I've twisted my ankle, I've done something like that. The only sort of easily bookable appointment without being an emergency is in 3 weeks' time. I phone them in 3 weeks' time and they go, oh, well, I couldn't get a GP appointment, but it's all right now. It's healed. It's fine. So it's those kind of things, isn't it? Sometimes, you can just, let something heal on its own because it's following that expected time course. And then other times, if it's getting worse and worse throughout those 3 weeks, then obviously you probably don't want to be waiting 3 weeks for an appointment. So it's difficult. But in terms of having that clear demarcation between what's acute pain and chronic pain, it is important. And I think when you go to the GP, it's really important when you're speaking to them, if somebody's had chronic pain for more than, as by definition, more than 3 months, it's really important that we don't just sort of ship them off to someone else to get another diagnosis. Actually sitting, taking the time to get a really good history from the patient. So for me, if somebody has got pain that is constant, they wake up in pain, they have pain throughout the day, and they go to bed in pain, there may well be something going on. If somebody's got pain which actually isn't there all the time, so for me, pain, I know, talking from our perspective, sort of with in sort of fitness, and as a doctor, we're talking a lot of sort of musculoskeletal pain, so your muscles when you're exercising. But as a GP, I see lots of chronic pain, so things like headaches. Okay, so people that have had headaches for more than 3 months can seem really concerning. People that have had, say, things like irritable bowel syndrome, because that can be really, really painful. Quite often people have had that for more than 3 months. When we were talking earlier, we touched on something called fibromyalgia, which we should probably talk about in a bit more. But there's lots of, and women can get these chronic pelvic pains. And so actually, when you come to your GP and you've had symptoms of some of the things I've just mentioned for 3 months or more, it's really important that actually the GP is taking a really good history of that pain, because if that pain comes and goes, okay, that might be an indication that actually it's not just a structural cause. If that pain is there all the time, it might be something underlying. But I think at any point before we do anything, it's getting a really good history from the patient about when did it start, how did it come on, did it then go away for a period of time and then come back, or have you been suffering with this the whole time? What else was going on in your life when this happened? Because I think that's really important as well. And then actually making sure that there is no underlying serious cause. So if it's musculoskeletal, it's going and having an x-ray to check that there's nothing wrong with the bones, or it might even be an MRI to check that there's nothing wrong with the soft tissues. So I think it's making sure that there isn't a structural problem with any of these conditions first. So, for example, if somebody comes to me with a headache, and they say, look, Dr. Hamilton, I've had this for 3 months. It's debilitating. I can't go to work anymore. It's ruining, my relationship. I can't do anything. I just go home and go to bed. That's got a huge impact on somebody. And I would never say, well, just go home and do some meditation and do some stress relief, it'll go away. You need to understand that headache and find out what's going on. And as a patient, and I'm sure I would be the same, your main concern is, have I got something horrible underlying? What is the cause of this headache? But in headaches anyway, and I think about 95 to 97% of the time, there isn't a serious structural issue going on. Okay, but you only know that if you do the tests. So you start off with a good history, you do the test, and once you realise that somebody hasn't got a brain tumour or anything really serious, which is very, very uncommon, but once you realise there isn't anything serious that is a physical structural issue underlying, then you can do some of the deeper work to then work out actually what else is going on in your life. Is this headache actually a symptom of something else? And that's the same with any kind of muscular pain as well. What else is going on in your life at that time?
Right. Okay. I think one thing I'd like to do before we actually do wrap up on this one today is just, I think it would be great to leave everybody that does listen to this now and in the future maybe a short timeline span of something happens at a certain point in time, and it just gives them a very clear indication as to what to do, what to expect, what to maybe pursue, in the sense of, like you said, giving enough history with a GP so they can take a really clear understanding of what's going on rather than just passing it on to somebody else. I think just a little bit of a process that helps people define acute, chronic, what to do and when, and kind of what to be mindful of or maybe take with them as evidence so that they can get this issue resolved as quick as possible. And I think that would just be a great way to just wrap this podcast up when we're done with that. So I'll circle back to that one in a minute. But we mentioned fibromyalgia. And I think more and more, I think people talk about fibromyalgia these days because although from my understanding, there is no root cause as to what fibromyalgia is. I think pain gets labeled as fibromyalgia, if I'm correct, and do correct me if I'm wrong in this. Pain gets labeled as fibromyalgia when it's an unexplained pain that keeps being persistent in different ways. So I've got a family member that is diagnosed with this, and it is a skin-related pain that it's unbearable to touch. So like even a change of direction in the wind can cause pain against the skin, and it flares up and decreases. And I know that it's stress-related and how it's triggered. Now, I haven't gone into the ins and outs as to whys, the whats, the tests that have been done, etc. All I know is, just to let you know, I've been diagnosed with fibromyalgia. It's really painful. It does this. I have flare-ups, etc., etc. Now, when this is being spoken about more, and again, just kind of on a weekly basis, when I'm on the radio and we talk about more mental health type things, fibromyalgia is one of these things that's coming into conversations a lot more commonly now, because whether, I don't know, people are being labeled with fibromyalgia because they can't get to the root cause of pain and problem, or if there's just more understanding of what it is, I would like to leave listeners with your description of what fibromyalgia is when it comes down to being diagnosed with this. And if you were comfortable to be able to just give us an outline as to if you are experiencing X, Y, or Z, it's likely to fall in the category of being fibromyalgia. Because I think a lot of people get misunderstood when it comes down to diagnosing what fibromyalgia really is.
So, I mean, this is actually something I'm really interested in, chronic pain in general and fibromyalgia. And I think the reason that I'm interested in, because if you take that bird's eye view of it about the patient's journey, if you like, how a bit of perspective and framing things in a certain way can have and that's for the doctor as well as the patient, can have a massive impact on how the patient feels. So, for example, with fibromyalgia, I see all the time somebody diagnosed with fibromyalgia. I'm the fifth or sixth GP that somebody's seen. They come to me, they're in terrible pain. They're on about 6 or 7 different pain medications that have been upped and upped and upped. They've been through the orthopedic team, they've been through the pain specialists, and then they're sort of saying, oh, I've got really bad back pain, Dr. Hamilton. I've had it for, 9 years now. Nobody's been able to do anything about it, but it's just getting worse. And it's frustrating for the patient. It's frustrating for the GP because, you look at all these really complicated painkillers that they're on. They've got horrible side effects. They might be causing weight gain. They may be causing the patient to get confused. And it can be a real sort of mess, to be honest, to try and sort out and help somebody. And I know the quickest thing is to go, yeah, just up one of these pain medications, yeah, you might feel a bit better, and that's a very quick consultation. But I don't think that's doing the patient justice at all.
Mm.
And I think maybe that's what's happened to them on lots of their other consultations. And again, this is nothing against the doctors, because there's a lot to do in a short amount of time, and you're not going to unpick somebody's pain in a 10-minute appointment. So the way that I try to approach it is actually be quite honest and go, in our 10-minute appointment, I'm not going to be able to fix this for you. But what I can do is have a really good chat to you, find out exactly what's gone on, where we are, where we're up to at this point, and then actually make some plans and book some other appointments, so we can actually have some trajectory about moving forward and making you, getting you to a better point than where you are now. So that's sort of a rambly way I've just talked about fibromyalgia. But so to answer your actual question is, so fibromyalgia is a diagnosis of exclusion. All right. So when I say that, what I mean is you've had lots of tests and we've ruled out that there's not a structural cause for that. So I might present to the GP saying I've had long-standing issues with both my arms. They're very painful. My shoulders are really painful. I don't like anyone touching me, and I can't even open a door or put a jumper on because it's too painful. And so you then you go to a GP, somebody examines you, can't see any swelling, can't see anything, and think, right, well, we better do some blood tests. We better go and send you for an X-ray or an ultrasound if your shoulders, or should we do an MRI of your spine or your neck, see if there's any problems there. So once everything has been properly investigated and we work out that you haven't got anything odd going on with your blood that would indicate, and it's something that's some inflammation or infection, once we've realised that there's nothing going on with your bones or your nerves or your soft tissues, it's probably safe to say that we've ruled up, everything else out. You've got pain in, lots of different body parts. There's not a structural cause. It will then, most likely get diagnosed as fibromyalgia. So the problem comes is when then, the medical profession say, well, you got your diagnosis, goodbye. That's not helpful. All you've been told is what it's not, what it is. So I think as long as you've had all the proper investigations, it's fine to give somebody a diagnosis of fibromyalgia. But what you then need to do is then the next step is, how do you help that person and how do you get them to understand what's going on? So for me, the way that I understand it, and I'm not a pain specialist, I'm a general practitioner. So my knowledge of how things work is that pain is a warning sign. Okay, so if you have an injury, it's a sign of you've injured something, you better rest it, you better let it heal. Other times you can get sort of a pain as a warning sign of just stop, something in your life isn't right. And it might not always be a direct injury. So you might not have a muscular problem, you might not have a bony problem or a nerve problem, you might have another problem, but that pain is your brain's way of saying stop, you've got to investigate what's going on. So that's what I try to do in those first couple of appointments with my patients, is have that really good chat to them. And quite often you'll find out that they've had, when that pain started, they were going through a horrible divorce, or an elderly parent has just died, or something like that has happened, and that person has carried on in their life and they've done all the things that they need to do to keep everything going. And actually, this is the way that their body is saying, stop, calm down, you can't keep going like this because it's too much. So sometimes it's more than just, there's an extra level of complexity than just, oh, I've got an arm pain, is the arm the problem? No, it's the you've got your arm, you've got your peripheral nervous system, and then your brain. But your brain has lots of centers. It's got an emotional center, it's got a memory center, it's got a center that picks up pain signals. And I think we've got to be sort of careful that we're looking holistically. So when I say holistically, we're looking at all parts of the patient rather than just one issue and being then closed off and saying, well, just take a painkiller, it'll get better. Because a lot of the time the painkillers stop working and you just get the side effects of the painkillers. And actually, if you do a bit of deeper work on what else is going on in their life, things start to fall into place.
See, that's I'm walking away learning something about this today, because I'm not being in close contact with fibromyalgia, but I'm hearing more and more people talk about whether they've been diagnosed or not, whether it's self-diagnosis, I don't know. But that specific word comes into the conversation, or it comes into a reasoning as to why they can't do something. Now, what you explained there was it's basically it's a diagnosis of the unexplained pain that isn't life-threatening in a way where it's degenerative, it's going to be causing XYZ issues. It's basically not going to cause any harm later on down the line, but it is a pain that is needing to be managed in a different way. Now, again, I think a lot of people look to it being a physical pain because I know a lot of the time it is due to sensitivity and touch and those kind of things. But even when you mentioned the psychological effect, like going through stressful events in stressful periods of time in life, etc., I think so many people discount all of those scenarios that happen when they do start experiencing pain of certain sorts, because we just kind of accept that stress is part of our lives. Or you're going through a career change, maybe it's an employment issue that's happened, or a relationship problem, and it's a psychological pain. But that psychological pain is then presented as something physical that you start to experience, and you don't know why, because you haven't changed anything, you haven't been anything different, but now all of a sudden you're getting this referred pain somewhere else. And like you mentioned there is a much more underlying, deeper root cause than just diagnosing somebody with unexplainable pain and it being labeled as fibromyalgia. Because I think once somebody has, this is the takeaway for me just from speaking about this today, is once somebody has that label of, I've been diagnosed with fibromyalgia, it's kind of like an excuse for the investigation to stop at that point, when the reality is that this is the start of figuring out what this unexplained pain is and how I can manage this later on down the line. Because now I know that it's not causing me life-threatening illnesses or injuries. It's not degenerative in any way. It's manageable to a degree, but it's unexplained. I think that next step is the bit that most people aren't taking when it comes down to this being in some kind of long-term chronic pain. So that for me is the takeaway straight away.
I mean, what I would say, I'd give another example. So, and I'll say, something that's maybe been quite unfairly labelled in the past. So certainly when I first became a doctor, a lot of issues, I probably didn't hear about fibromyalgia as much as I do now, but I did quite often hear about chronic back pain. So people that couldn't go to work, couldn't do anything because they had chronic back pain. And it would be one of the things that we'd sign sick notes for all the time, chronic back pain. And then I can remember going on a course about chronic back pain, and it was making the doctors frame it differently. And I can remember they had a patient in, and he did have chronic back pain. I think he worked in the NHS, and he did something at work, and he bent over. I think he was helping lift a patient or something, and he hurt his back. And then that led to lots of time off work. I think relationship breakdown. This back injury sort of essentially made his whole life very difficult. And then I think he was saying that he felt very much labelled as he was lazy, didn't want to work, when that was really quite far from the truth. But then he was really honest, and he was saying that actually when he went on holiday or he did something nice, that back pain was a lot better. And I think he was saying that he felt a little bit of a fraud because he was having scans on his back, and actually nobody really found any more than just general wear and tear. And he was sort of saying that he was frightened to go and do anything physical in case someone saw him and thought, oh, he's a fraud. Or he was quite worried about, pushing himself. And actually then what he said was that he actually didn't like his job, and that actually managers weren't very supportive. And then he actually then said he decided to leave that job, found another job, and actually the back pain went away. And I thought that was quite interesting, because he was just, and he actually put it together was, I did a lot of deep work. I thought about everything. That pain was real. That pain was not, it wasn't not there. It wasn't in my head. But I think for him, he realized that if he went on holiday or he did something else, that pain went away. He actually got a job that he enjoyed. His relationship got better, and that pain was better. And for me, the other thing that he was sort of saying was about reframing how he thought about things. So he did start going to the gym. He did start exercising. And I think it's very much about, once you know that there isn't a reason that you can't do exercise, that's all been cleared, because I don't want anybody doing exercise if they do have a structural problem, which could be made worse. But once you've had all the scans and you've had all the therapy, and somebody says, look, you could do a bit of mild exercise, to actually approach that going, I mean, I think this chap that did this talk was probably late 30s. And, he sort of said, the way I approach exercise is that I'm a fit man in my late 30s. I don't have any medical conditions. I should be able to do this exercise. So he didn't go into that exercise really cautious. And I think if you go into it and you think, oh my God, this is going to really, really hurt me, you are going to build up that neurocircuitry where actually you associate that exercise with pain, and that every time you do that exercise that there will be elements of pain. So I think it's really important how we sort of frame things. And actually, I mean, that chap, I thought, had a really deep level of self-understanding and self-knowledge. But he then realised he had to get at that job was making him unwell, the stresses, and that all happened long before the back injury. And if it hadn't been the back injury, it would have probably been something else.
I already know that this conversation could go on for another. We could double, triple the time length on what we've had today, just talking about, because every time something's mentioned, my mind goes to another place, thinking, well, what about the person that's struggled with X, or what about the person that's experiencing Y? And because there are so many avenues, where it's psychological, physical, degenerative, there's so many avenues that you can start unfolding the pages of when it comes down to chronic pain. It's no wonder it takes people either so long to start looking as to why they get the pain, or so long to get an understanding or diagnosis of what is actually going on. So I said I'd circle back around to it, and I think this will be a great way to just kind of sum up the whole process of understanding where you are at currently. So if you're listening to this podcast and you're at a point where pain is quite an everyday occurrence, you feel like you've accepted something, that you've got to live with it, and this is life now, and it's maybe impacting the quality of life more than what it should be doing, then there is potentially a process that you should be aware of, which, if I've got this right, I'm going to, from my understanding, so I'm going to take the information that you've given in this podcast and put my understanding together of, I'm the individual, and obviously at this point, I wouldn't know where this pain is coming from, but I've got, I've got a pain, we'll go with back pain, because it is quite a common one. I've got a back pain, and it's been mild on and off for a long period of time, years, let's say. It comes and goes. It's nothing that's not been managed, but now all of a sudden, it's starting to impact my quality of life. Okay, so from my understanding from listening to this podcast, I could determine in my mind, is this acute pain or is this chronic pain? If this pain is going away in 6 to 8 weeks' time, then I know this is acute pain, and it is something that will, like you said, the body will regenerate, it will heal itself, and you can kind of get back into normality. If there is something that keeps creating the same issue over and over again, it's likely that you're doing something in your daily life that's triggering this scenario to keep happening. But if I was to be in pain for plus 3 months, and I've been taking paracetamol, pain management medication, ibuprofen, those kind of things, and it maybe takes the edge off, But I'm finding reasons to say that, well, I need to sit down a bit more frequently, or I can't do a standing job, or I can't be as mobile as I was. And I'm trying to manage this by stopping myself from moving, and it's impacting my quality of life. And I've been doing this for multiple months now. I've moved into the chronic pain region, and that's the point where really I need to start looking at getting the test done, getting to the root cause of why this is coming into, why it's affecting my life the way that it would be, and then hopefully getting either a plan of action, a diagnosis of some sort, or a solution that's going to help me understand how to manage what I'm experiencing long term to get back into, fingers crossed, that there is no long term, this pain sticks around type scenario. I understand that for some people that is the case. But my understanding would be to try and get past the chronic pain back into normal life, potentially pain free or just at a manageable point, like where you say that you've been cleared for exercise. You can move with XYZ information that you've been given by a GP, specialist, etc. And you're just not using it then as an excuse to say, well, I've got chronic pain. If I move, I will be in pain, therefore I won't move.
Yeah, and I think that's a good summary. That's a really good summary. What I would always say is, if you are worried about something, if do go and see your GP, get them checked. And I don't want anyone to think that they've got to put up with something that's painful and horrible for 3 months to then suddenly say, I've got chronic pain now, something needs to be done. I think you do need to go to GP before that point, definitely.
Right.
If you're worried about something. So if you think you've broken your ankle, yes, absolutely, you need to go and get that checked out, have you? And then if you haven't, then you should be told roughly what to expect. How long is this going to take to heal? If you say had an injury or you've had an infection that's been treated. And then if things, if you are getting to that sort of 3-month mark and things haven't been resolved, you absolutely want to push to go and get tests. All right. So nobody
I think
should
that's
be
something that people might feel uncomfortable with, is like because you've obviously had multiple appointments by this point with GPs, and I know people will get frustrated with going backwards and forwards and trying to book appointments and the whole frustration of it all. I think maybe that is something that people do get uncomfortable with when it comes to pushing for those further tests. It's what would somebody ask to be if they get to that point where it's like, I'm in chronic pain, I know that I am, I need to push for further tests. What would be the best way for somebody to ask a GP to be able to go down that route?
So, I mean, when I say sort of push for tests, now I'm absolutely, I would definitely hope that most GPs and sort of nurse practitioners we all have that sort of same training and thought pattern. Let's rule out all these serious physical things first. So I would really hope in most of the cases that's been done. I'm sure it has. The problem we have in the NHS is because everything is so busy and there's that lack of consistency and continuity. So if you came to see me, Andy, and you came 3 or 4 times, we'd be having a plan and working through something. The problem is if you see me and then Dr. Smith and then one of the nurse practitioners and something else, it's harder to put all of those bits together. So I think
the best thing to do really is just ask to see the same doctor with the problem that you keep going back, so you can build the history on that.
Ideally, that would be great. But in some cases, that's not always going to be possible.
Yeah.
So, I mean, what I would say is really for the patient to sort of keep a record and be sort of saying, look, I've seen 3 different people now. We've covered this, this, and this. And, we will be able to see that from your medical record. But actually, I'm concerned about X, Y, and Z. Let us know what you're worried about. And then we can either relay your fears or we can, do some tests to check that. So I think my point is nobody should be getting a diagnosis of, say, fibromyalgia or something like that without there being tests, without there being a really full and thorough history. What's going on? When did it start? What makes it worse, better, that kind of thing. Having a physical examination, somebody checking you over, having blood tests, or you might have a scan or an x-ray. It's at that. So when I say sort of, and I worry about sometimes people will just look up on the internet and say, oh, I've got fibromyalgia because I tick all these boxes. yes, that might be a helpful indicator, and you can definitely go and sort of do that bit of research and say, look, and then have an appointment with your GP and say, well, I've done all this research. I think I'm meeting these criteria, but actually I don't know. And then hopefully that's when the medical profession would then pitch in and go, well, it could be, but let's exclude everything else first. So
I
I
think that'd be
think,
a good catalyst to get those tests begun as well, so that you can start that process of elimination at that point. I think that would be good for not just being understanding of yourself, but taking that information with you so that you can actually speed up that process.
yeah. So, and I think that goes for a lot of those conditions that I said, things like your headaches, for things like irritable bowel syndrome. Before we just label somebody as having irritable bowel syndrome, we're going to do tests because we want to make sure nothing else is going on. Once we know that there isn't anything else going on, we can help the patient then move forwards. So, I think in terms of sort of as you said, trying to leave people with an idea about what to do. So yes, absolutely. If you're worried about anything, go and see your GP. Have a chat with your GP. If things are going on for longer than 3 months, I would have hoped that you'd have had some investigations. But what I would also say is be open to sort of, if you do get a diagnosis of something like fibromyalgia or something like that, sometimes people can feel a bit fobbed off because they feel, oh, it's just, they just don't know what's wrong with me, so they've told me it's this. I would counter that with, actually, we've ruled out, and that's good. It's really good that we haven't found something horrible going on with your nerves or a compression fracture in your bones or something. That's all good news. And it means that we can then move forward. But actually, you have to be open to thinking about, this is the way I explain it is, this is a neurocircuitry problem. So there is a problem. It's not made up. It's not in your mind. There is a physical perception of this pain which is real, and actually we need to try and sort that out. And I think one of the things I'm quite passionate about is not just to overload lots of people with highly addictive painkillers that is going to cause lots of other side effects. Painkillers do have their place in rehabilitation, and that's great. But I do really worry when I see, especially, well, young and old patients, when I see patients on lots and lots of medications and the doses are just going up and up and up. I don't think that is a good way to treat things. But it can be very difficult to treat people in other ways. But I think there are other ways. But I think people have to be open to it. So if that's anything that I can do from this podcast, is say, just be open to exploring other ways of managing your pain if some of the conventional things haven't worked. And that's got to be better than having lots and lots of painkillers that are going to have side effects. That's how I would want to be treated.
I think that is the perfect way to be wrapping up this one. Being told by the GP themselves, this is not coming from a Google search or a WebMD type thing. It's somebody actually being told how they should be managing this, what they should be looking for, the processes of. So, as always, thank you for joining me on Impact Your Revolution. This is always, I know for a fact that these MedFit episodes that we do, they may not be of benefit to somebody right at this very moment. This might be an awareness to somebody, but at some point, somebody will go, oh, I listened to that episode. Now I'm experiencing this, or somebody that I know is experiencing this. And it may increase the speed at which you get help and support. It may be a better understanding of what's going on in life and what's going on with your body right now. Hopefully, we leave you with some kind of information that you can take away, apply to your daily life, get seen for the support that you know that you need, and fingers crossed, and I wish this upon everybody, you get back to living life the way that you want to live it on your terms. So thank you, Dr. Jill Hamilton, for joining me yet again. This obviously is not going to be the last one, so we will see you in a few weeks' time. As always, if there is something that you would like us to cover, you can reach out to myself. You can contact me on pretty much any of the social media platforms at Coach Andy James, or you can email in info@impacthealthclub.co.uk, and we can look at maybe covering a topic that you want some information on. Bring this with my perspective from fitness and Dr. Jill Hamilton's perspective from a medical angle too. So again, thank you, Jill. You have an awesome day, You take care. Speak soon.